Leading us in diagnosis day in and day out at ICH. Over to Madam.
Good afternoon to all. I would like to thank the organizers for giving me this opportunity. Thank you, Sri Devi, for the wonderful introduction. So, lysosomal storage disorders, though rare, collectively they are common, and the clinical suspicion for the mic. Can I have the? Yes, I have that mic. So, can present with dysmorphic features. Dysosmosis multiplex, cardiomegaly, corneal clouding, cherry red spot, developmental delay, hypotonia, seizures, intellectual disability, ataxia and spasticity. Regarding the Gaucher's disease, it's a disorder of the sphingolipid metacatabolism. The enzyme beta-galactoglucosidase is deficient, so there is accumulation of glucose cerebroside in various tissues, and there are three types of Gaucher disease. The type 1 is absence of neurological features, type 2 and 3 present with neurological symptoms. So this child, a 2-year-old female child, presented with recurrent episodes of fever, abdominal distension for 1 year duration, gross pallor, liver grossly enlarged, and there was splenomegaly. X-ray abdomen and ultrasound showed gross hepatosplenomegaly. Hemoglobin MCV, MCH were low. Bone marrow aspiration cytology showed the characteristic crinkled tissue paper appearance. So, biochemical assessment of Gaucher's disease, we have to do the complete blood count. Liver function test will be slight elevation of the enzymes, and enzyme beta-galactoglucosidase will be low. The enzyme chitotriosidase will be elevated, and mutational analysis is confirmatory. So, the enzyme assay for this patient, the beta-glucosidase was very much low, and the chitotriosidase was very much elevated. So, now enzyme replacement therapy is possible here. Even in ICH we have the facility. So, the 25% decrease in liver and spleen volume after 6 months of therapy, and symptomatic improvement within 1 year of treatment, and it takes longer period for radiological response. So, the next one is the Pompe disease. It's a glycogen storage disorder type 2, accumulation of glycogen in the lysosomes due to the deficiency of the enzyme alpha 1,4-glucosidase. So, mainly it affects the skeletal, cardiac and respiratory muscles, and there is massive deposition of glycogen where there is progressive cardiomyopathy, generalized muscle weakness and hypotonia, and you can see the typical floppy baby. Since only 1 to 3% of glycogen is stored in the lysosome, unlike other glycogen storage disorders, it does not present with hypoglycemia. So, this child, 6-month-old female child, presented with dysmorphic faces, recurrent respiratory tract infection, feeding difficulties, developmental delay and progressive muscle weakness. You can see the typical floppy baby here, and chest X-ray and echo showed dilated cardiomyopathy. Serum creatine kinase was elevated, and there is moderate elevation of liver enzymes. The enzyme levels were very much low. So, this is a case of late onset Pompe disease. So, a 10-year-old child presented with proximal muscle weakness of lower limbs, respiratory distress and recurrent respiratory tract infection, and the serum creatine and liver enzymes will mildly elevated. The first sign is difficulty in climbing stairs and squatting. A key clinical feature that helps to distinguish late onset Pompe disease from other neuromuscular disorders is the early involvement of respiratory muscles. Here the enzyme assay was done, and alpha glucosidase levels were very much low. And the difference between early onset and late onset is there is no cardiac involvement in late involvement of and in infantile Pompe you see the characteristic floppy baby appearance, and late onset the lower limbs are affected and Gower sign is positive. The biochemical assessment is plasma glucose, which is normal, and serum creatine kinase is elevated, liver enzymes are elevated, and mutational analysis is confirmatory. So, enzyme replacement therapy is available for Pompe disease, for the infantile Pompe and late onset Pompe disease. So, prenatal diagnosis in the subsequent pregnancy in families with affected child. This is the first child who expired. The enzyme assay was very low, and whole exome sequencing was done, which was found out to be homozygous for GAA gene, and father and mother were screened and found to be heterozygous, and in the subsequent pregnancy amniotic fluid sample was collected, and it turned out to be homozygous. So counseling plays an important role. So the next one is Niemann-Pick disease. Due to the deficiency of the enzyme sphingomyelinase, and there is deposition of sphingomyelin mainly in the brain. So there are three types. Type A and B are due to sphingomyelinase deficiency, and C is a totally different disorder due to defective cholesterol transport. Type A is presence with hepatosplenomegaly and neurodevelopmental regression. Cherry red spot is seen, whereas type B there is no neurological involvement. So 7-month-old child presented with feeding difficulties, abdominal distension, delayed milestones, and hepatosplenomegaly. Cherry red spot was seen on ophthalmic examination. Liver biopsy showed foam cells. Enzyme assay was very low, and genetic mutations showed homozygous mutation for SMPD1 gene. And this is the genetic whole exome sequencing of the first child, which shows homozygous variant for Niemann-Pick disease. Mother and father were screened, which they showed heterozygous mutation of the same gene. And in the second, the counseling was done, and in the antenatal period for the second pregnancy, chorionic villus sample was collected, and whole exome sequencing was done. It was found to be homozygous for Niemann-Pick disease, and the MTP was done, and fetus terminated. And again, the counseling was done, and the mother had come during the antenatal period for the third pregnancy, and it turned out to be homozygous, but the parents refused to terminate the pregnancy, and this child presented with hepatomegaly, and so we had sent the sample for enzyme assay. So Tay-Sachs disease is due to accumulation of GM2 gangliosides in the brain. So this 1-year-old female child presented with macrocephaly, delayed milestones, recurrent seizures, refractory to anticonvulsants, absent eye contact, unresponsive to outside world, persistent moro or startle reflex. It's abnormal beyond 5 months, and cherry red spot was present. The enzyme hexosaminase A was very much low. So what the distinguishing features for Tay-Sachs and Sandoff for in Sandoff, both the hexosaminase A and B are absent. In addition, there is visceral organ involvement in Sandoff. Mucopolysaccharidosis is deficiency of the lysosomal enzymes which degrade glucosaminoglycans. So there is impaired degradation of dermatan sulfate, heparan sulfate, keratin sulfate. So impairment of heparan sulfate degradation causes intellectual disability, whereas others cause mesenchymal connective tissue abnormalities. Mucopolysaccharidosis type 1 is due to deficiency of the enzyme alpha-1 alpha-L iduronidase, which degrades dermatan sulfate and heparan sulfate. So the early onset severe type is Hurler, which presents with mental retardation. Hurler-Shees is intermediate, and she is late onset and with mild and normal mentation. So, MPS 1 presents with dysostosis multiplex, short stature, coarse faces, corneal clouding, valvular dysplasia, and hepatosplenomegaly and hernia. So full skeletal survey is mandatory. So this child presented with short stature, exaggerated lumbar lordosis, flexion deformities of elbow, corneal opacity, umbilical hernia, and hepatosplenomegaly, and biochemical assessment was done. The basic urine metabolic screening, the citramide test was positive. Urinary gag, the quantitative test was done, which was gags were elevated. The qualitative test, heparan sulfate and dermatan sulfate were elevated. Enzyme assay was done. Alpha iduronase levels were very much low, and genetic testing proved to be homozygous mutation. So next is the Hunter type 2 MPS. So it's due to the deficiency of the enzyme iduronate sulfatase, which degrades heparan sulfate and dermatan sulfate. It presents with similar features of Hurler, but there is no corneal clouding. Somatic features are milder and so have slow progression, and extensive Mongolian spots are present. Urinary gag shows both elevated HS and DS. Enzyme assay was done. the patient's, the 7-year-old child showed very low enzyme levels. Mother, since it's an X-linked, only mother was screened. So mother showed moderate decrease in the enzyme levels, and 3-month old male sibling enzyme assay showed very low enzyme levels. So Hunter disease is X-linked disorder. So we don't call it as homozygous, it's hemizygous. So that is the whole exome sequencing of the affected child. Mother showed heterozygous mutation, and the younger male sibling showed the hemizygous mutation. MPS 3, Sanfilippo syndrome, it's an enzyme defective in the degradation of heparin sulfate. This is clinically unique because there is disproportionate involvement of CNS. And though there is dull rigid phases is there, but it is due to the cerebral deterioration in contrast to the local tissue changes in Hurler. So urinary GAG was elevated and heparin sulfate was elevated, and the enzyme showed very low levels. Mutational analysis confirmed the diagnosis. Morquio disease, Morquio syndrome is MPS 4A. It's a defect in degradation of keratin sulfate due to the deficiency of the enzyme galactose 6 sulfate sulfatase. Here there's preservation of intelligence. So this is a child who presented with postphases, hepatomegaly, skeletal deformity and joint contractures. Urinary GAG showed elevated GAG and keratin sulfate was elevated. Citramide test was positive. Enzyme levels were very low and the whole exome sequencing confirmed the diagnosis. Here the main problem is there is instability of the hypoplastic odontoid process, which can lead to atlantoaxial subluxation and quadriparesis. So the sample for lysosomal assay is dry blood spot. So enzyme replacement therapy is available now, and these are the for type 1, type 2, Pompe, MPS 1, MPS 2 and 6. Apart from the enzyme replacement therapy, the other options are splenectomy, substrate reduction therapy, bisphosphonates, bone marrow transplant and gene therapy. So the success story here, the MPS 1 child, Hurler syndrome, was diagnosed. So you can see the corneal clouding here. The enzyme assay was the iduronidase was very much low, and the whole exome sequencing showed homozygous mutation. And this child was diagnosed in 2017 and had come for review before starting the ERT. And the child had completed 32 cycles of enzyme infusion, and you can see the child walking confidently with her grandfather for the 33rd dose of enzyme infusion at daycare center. Thank you.
I thank the speaker, Professor Pramila Madam, for that crisp and sweet presentation on LSD. Thank you, ma'am. There is a question.
Madam, regarding Niemann-Pick disease, type 1, type A and type B. Type B, you did mention no neurological involvement, no? Is that right? Am I right? Type B, no neurological involvement. But when you see that genetic report, if you just go back to the genetic report, it does mention that particular child you mentioned, which did have a clinical neurological involvement. The genetic report says type B, type A. Did you notice that?
That is not that child, sir. I just got that.
The reason I am saying is,
yes,
I had a similar child, similar presentation. But again, the type B and type A overlap is there, neurological issues. I don't think they were very...
We cannot segregate them.
There is no clear demarcation.
Yes, sir.
Type A and type B overlap many of the cases.
Yes, sir.
Thank you, sir.